So just in the interest of time, I'm gonna blow through just for the deformity talk, just some of the parameters that we should look at, and then we'll end with a couple of complications and try and get out of here in 10 minutes. So cervical parameters, when you're looking at deformity, we understand the relevance of that in the thoracolumbar spine, and there, we can talk about that for hours. But there are relevant parameters that I think are becoming more evident, and a lot of this we naturally understand, but we haven't necessarily standardized. Chin-brow vertical angle is one that is important, especially when you're doing deformity, even thoracic deformity. There's no normal defined, but clinical outcomes are sort of acceptable, plus or minus 10 degrees, and it's a line measured from the brow to the chin to the vertical line while the patient stands with the hips and knees extended. The T1 slope, this is one that I think is an important one, and it has some relevance even in arthroplasty literature, but basically if this tilt falls outside of the range, which is 13 to 25 degrees, there may be another deformity going on below, and this might be a sign for you to get images of the thoracolumbar spine. Now, I generally get full spine images now, even on my cervical cases. I think that was a thing that came up yesterday. But if you do not, and you're just getting routine cervical x-rays for that kind of finding, if you have a big T1 slope, you may want to consider, just so you understand the big picture. It may not change your surgical plan, but something to understand.
Does it change your surgical plan? You actually take that cervical patient and do a thoracic fusion because they're hypertrophic.
If I'm doing a posterior cervical for that patient, it does prompt me to extend it down into the T2 level, sometimes below.
Also, this is sometimes how you recognize thoracic kyphosis and sort of neck pain. It could be compensatory.
The cervical sagittal vertical axis, this is the distance between the plumb line from the C2 centroid to the posterior superior corner of C7. And there are some good studies that have been out even in the last 6-8 years, but basically showed that the quality scores started to worsen when you were greater than 40 millimeters. So even though the patient may have adequate cervical lordosis, if their cervical axis is very forward, just like we see in sagittal balance and thoracolumbar spine, they had worse outcomes, worse satisfaction. And then cervical lordosis, this is not necessarily standard. The rough range is 20 to 40 degrees, but it's very patient specific. And I think this is where the T1 slope can help you determine if there's some compensation going on if you have hyperlordosis because of a thoracolumbar deformity. So, basically these outcomes are being collected. The big issue I think that will come to fruition if these parameters are actually relevant or not, especially with the cervical vertical axis and T1 slope, is the rate of adjacent segment disease. And I think that data is being collected, and there was a small presentation of a small number of patients at CSRS this year that this is something that I think if we understand the contribution of lack of alignment in thoracolumbar disease and the risk of adjacent segment, I think we're going to understand this a little bit better in the cervical spine, that maybe a thoracolumbar deformity is affecting why we get a adjacent segment disease after 1-2 level ACDF sometimes. Okay, so we're going to move on to just some cases of the complications, and then we'll get out on the